I'm Phil Kempo, and I'm one of the fours. We'll be talking about blunt cerebrovascular injury today. So BCVI is one of the more uncommon diagnoses that we get in blunt trauma patients. And the majority of these are actually asymptomatic at time of diagnosis. And so we will get into that in quite a bit of detail as to who should be getting screened for this later on in the talk. But these are mostly just picked up on imaging because you're screening them based on mechanism. If the diagnosis actually does occur when they are symptomatic because you have not screened them and they actually had this injury, and then 1 or 2 days into their hospital course, they begin to develop neurologic symptoms, there's actually pretty substantial morbidity and mortality associated with that. Those 80 and 40% numbers there are more historical than not, and I think recent series have demonstrated that those are probably a little bit high, but still, like that, it's not a benign thing to miss one of these and have them develop symptoms. Let's see. And then in the context, these are often associated with a pretty substantial mechanism of injury, which goes to the last point there, in that when you're treating these and when you're thinking about treating these, you need to be mindful of other injuries that they also have. So specifically TBI concurrently presents with BCVI in a not small number of these patients. And you obviously can't treat those patients the same, at least initially. And so just being mindful of other injuries as well. So these injuries occur with disruption of at least one layer of the carotid vertebral artery following a high injury mechanism. And again, think like a high energy MBC or a direct blow to the neck, but something that can generate this kind of disruption. Subendothelial collagen is exposed, you get activation of platelets and then thrombus formation with or without thromboembolism. And that's how these patients will end up developing neurologic symptoms. Is typically a thrombus forms and then breaks off and causes a stroke. Alternatively, you can have thrombus formation to such an extent that you get actual occlusion of that artery, though that's a little bit less common. ICA injuries are more typically associated with hyperflexion, hyperextension, and rotation. So just more dramatic mechanism of injury, more kinetic energy, whereas the vertebral artery injuries, just thinking about how those arteries course, are more associated with fractures that involve the foramen of the cervical vertebrae, and particularly C1 through C3. And then in a third of cases, greater than one artery is affected. So if you have enough energy in the mechanism to injure one, you likely have enough energy to injure multiple. And so that's something to be mindful of as well. And the outcomes associated as more and more arteries get involved are not the same. You know, your risk of stroke, risk of a problem increases with number of arteries affected. So again, most common mechanism of ischemic stroke following these is thromboembolism. So thrombus forms at the site of injury, breaks off and embolizes distally into the cerebral circulation. We'll talk about this a little bit later, but transcranial Doppler can be used to sort of evaluate the risk associated with some of these injuries. And so 8 emboli per hour on transcranial Doppler is strongly associated with an impending embolic stroke. And then the majority of ischemic strokes either occur before admission, so after injury, but while the patient is on the way to the hospital, or within 72 hours of injury. So if you have someone who arrives asymptomatic but has one of these injuries, they will typically become symptomatic from it, if they're going to become symptomatic from it in the first 2 or 3 days after they've been admitted. Let's see, 40% of these are present on admission, so occur in the field prior to arrival. And then if you initiate prompt treatment and are able to initiate prompt treatment, if there are other injuries allow for it, which consists of antiplatelet or antithrombotic therapy, again, we'll get into that, you reduce the clinical stroke rate to around 10 or 20%, depending on what study you read. So assessment of these patients begins the exact same way as you would any other trauma patient: ABCs, primary survey, secondary survey, with particular attention given to their mechanism of injury and then the injury patterns that you're seeing in these patients. So, you know, high speed MBC should raise concern for this. If they have a lot of facial trauma, if they have neck tenderness, all of these things can sort of clue you in that this is a potential injury that you need to be looking out for. And then finally, other findings on CT head and CT C spine before you get a neck angio can also be indicative that you need to be examining these patients for that injury. Diagnosis historically, as with most things, was formal angiography. Now we use CT angiography. It approaches 100% sensitivity with the newer scanners. It's a very, very good tool to use. There's really no role for duplex ultrasound in screening. It has low sensitivity for these injuries, and also there are areas of the neck that are pretty inaccessible for this mechanism or for this modality. And then similarly, really no role for MRA in screening. It has a lower sensitivity than a CT scanner, and then also a high misclassification rate of injuries.
And so Christina, any downsides to cerebral angiography? Why would we move away from other than it being just inconvenient? And it has its own stroke rate associated with it, which seems silly to put patients through. Concerned about like a 1% stroke rate just associated with angiography. So it's we continue to label it as the gold standard, or we label it as gold standard. Every paper you'll read, I can't imagine that a 2D orthogonal view or non-orthogonal view is actually better than CT view, especially reconstruction. So just if you want to do vascular, just things to think about as you come across these statements in literature. It's kind of nonsensical, honestly, to call it the gold standard, but it's pretty good.
But historic.
Yes. Historic,
not actual.
No, it's not nonsensical in all. It will be written accordingly. Never even think about these.
So these injuries can be classified by Denver criteria, and those are listed here. I don't think this projects terribly well. So the Denver one is less than 25, or luminal irregularity or dissection with less than 25% luminal narrowing. Type 2 is dissection or hematoma with greater than 25% luminal narrowing. Type 3 is a traumatic aneurysm, type 4 is occlusion, and type 5 is transection. And then on the right side of the screen is the proportion of these injuries which are of each type, and they're split up by carotid and vertebral artery. So type 1 being the most common in the carotid artery realm and decreasing with increasing grade of injury. And then in vertebral artery, the most common is an occlusion, followed by type 1 and then type 2, with traumatic aneurysms and transections being rare. So indications for, sorry.
Can you go back one slide?
Sir.
For documentation purposes, we don't do it here, but we really should start that. We should document what the Denver, or whatever you want to call it, classification of injury is. Because as you can see from this slide, they're very different. So a Denver 1 is completely different than a Denver 5. And so to just say that there is an injury is really insufficient. So if you put that on there, it just adds to what our list actually says. And when you're discussing it, if you discuss them with these terms, it paints a better picture to the person you're talking to about how bad the injury is.
Yes.
Do you have any table for that, like the different stroke?
Yes. Yeah. In a few slides. That's okay. So indications for imaging, the original sort of screening criteria that were proposed for this were by the Denver group. I can make this talk publicly available because there's no way that you can read all of these small things, but that sort of has evolved into the expanded Denver criteria. I think that was in 2011 or 2012, and those are listed in with the blue arrows. And really, this is a pretty comprehensive, list of injuries, where if you found any of these injuries on either physical exam or initial imaging, that would warrant screening with a CT angiogram. So again, very, very comprehensive list. But that being said, you can still, here's our CPG, our guidelines from our CPG as well. So we take a number of those, and particularly from the original Denver criteria. And the thing that's also not on here is just, clinical context and staff discretion. And that can, be enough of an indication to get a screening CTA as well. And then certainly if they are symptomatic at all, any neurologic abnormality not explained by a known injury, or if they have suspected arterial bleeding from any of those orifices, then you should get a CTA. So there's been a lot of discussion. So guidelines suggest, using a screening algorithm and not universally screening these patients, and that's true. I think both East and West recommend that, but there has been recently a move towards, maybe we should be actually universally screening these patients. And the reason for that is that up to 20% of asymptomatic blunt cerebrovascular injuries are not captured even with the extended criteria. So this was a study that came out in 2020 that looked at a single center's experience prior to universal screening and then after. And so it's a retrospective study comparing same center and in theory, same practice pattern, except for the institution of or implementation of this universal screening criteria. And once they started universally screening these patients, they compared various criteria for the more selective screening, and they looked at how many injuries they would be catching, how many they would be missing, and they found that even with the extended Denver criteria, up to 20% of these patients were not captured. And so even with that, again, pretty rigorous, pretty general set of criteria, you're missing a number of these injuries, and in particular, you're missing a number of high-grade injuries. So 23% of the grade 3 or above blunt cerebrovascular injuries were not captured, even with the extended criteria. And this was just published in Journal Trauma in 2021. I misspoke earlier. This is a study that adopted it, and then similar study design to the last one, reviewed retrospective data. A large patient population of over 6,000, incidence of injury was about 7%, so higher than the first paper. And they demonstrated similarly that even with the extended Denver criteria, they're missing 25% of injuries. And so again, 20 to 25% of injuries are missed, even with those criteria. Should we be screening all patients? And that's something that I don't think has been, really taken into the mainstream yet. I don't think the majority of places are doing that, but I know we talked about doing this here, at least last year, amongst some of the trauma faculty, but it's not something that we do here yet. So this is a study, I think this was in actually like a radiology journal, but this looks at 10 years of experience with natural history of BCI, how these injuries evolve. It was a retrospective study that examined.
Sorry, did you talk about why we don't screen like that?
I mean, resource utilization and radiation exposure, as well as I think those are it. They're going to get the contrast load anyway because of how we protocol our studies.
Really, there's more than that.
The whole unboxing of indeterminate BCV.
Right. Sure. So like you don't know the natural history of how, like, if you're catching those injuries, are they ever going to become symptomatic, and then like do they need treatment?
But even more than that, so you end up on this like pathway of nothingness. You end up doing more and more and more tests too, until you end up with a complication for a test for a problem that the patient never had. So that's why we don't, like, if your negative predictive value is so high that the test is not going to be helpful, that you shouldn't order it.
And I think, yeah, to Dr. Arnold Lloyd's point, that is like, so all these papers that talk about universal screening, that is great that they unmask more injuries. What they don't do is then go back and redo the math on how frequently these patients are actually symptomatic. Because that data is from really strict screening. So if we are actually going to, change the denominator that much, the rate at which these patients are symptomatic would probably drop dramatically.
Yes.
So
yeah,
that is something that should also be considered, because the treatment in the setting of trauma is to thin their blood in some fashion, right? So it's
not free.
So sorry to do this to you, but since now I opened up the statistics and we have junior learners in here, can you tell us about predictive values so that we can check off that we talked about statistics?
So sensitivity, specificity, negative, positive, and negative predictive value are sort of the four. Can I just draw it? Yeah, because that's going to make me.
But I think while Phil is drawing this, maybe Frank, if you could talk, there's sensitivity, specificity, and then positive and negative predictive value. One of those categories is affected by the prevalence of a disease, and one of them is not. Which is affected by the prevalence of a disease, and which one is not.
The predictive values are?
Yes, so sensitivity, specificity should be a function of the test alone. It should get at the quality of the test that you're using. The positive and negative predictive values have to do with prevalence of disease, which is exactly why I was saying, like Phil is discussing, unmasking 25% missed injury rate, that should dramatically change your denominator and then change the positive and negative predictive value of a clinically significant injury.
I'm going to get this one.
And so this seems super academic, but this is really the basis of all that we do in trauma, like what we screen and what we don't screen, and why we just get a head CT scan in some people, and why you get like the trauma super package on other people. It's all based on what our clinical exam shows and what our positive and negative predictive values are.
So the sensitivity is how many of the, if the patient has a condition, how many of those conditions are you actually catching with your test? Whereas positive predictive value is if you have a positive result on your test, how many of those patients actually have the condition?
Yes.
Sufficient. Okay.
The sensitivity, like A over A plus C, specificity,
Yes.
D over D plus B, positive predictive value A over A plus B going across, and negative predictive value D over D plus C. It's not just for medical students, we have to know this.
So this is a basically a 10-year review of 1,200 patients and just over 1,600 vessels, looking at injury patterns and post-injury courses, and again showing that generally grades 1 and 2 are the more frequently injured or more frequent degrees of injury, though grade 4 is a little bit more pronounced in this review. Again, in this group, 24 or almost 30% of patients had more than one vessel injured. And then mechanism of injury here, the vast majority of these were MVC or related motor collision. But you can look here, this is I think what Dr. Nissen was getting at with risk of stroke, and it's broken out by vessel type in this first one. So the top is carotid, the middle one is vertebral, and the bottom group is both were injured. And so stroke risk with one ICA injury is about 10, two ICA injuries was about 20%, vertebral artery 5% for one, and then 14% for two. And then broken out by, again, vessel, but then also degree of injury. You can see that for both, the stroke risk was increasing with degree of injury. So to the extent of like 4s and 5s were 50 to 60% stroke rate for the carotid artery injuries. So they looked again at again, this is retrospective, so all just, you know, sort of demonstrating their practice pattern and their results over 10 years. But looking at antiplatelet and anticoagulation therapy. And the bottom of this shows that, I think it's projecting well enough, any antiplatelet or anticoagulant used, yes, no, and treatment with either one of those things reduces your risk of disease progression. Didn't really have an impact on either improvement of disease or resolution of disease, but prevented progression to a pretty significant extent. And that multivariate regression includes all injury grades, but is broken out into low and high. And for with the low injury grade of Denver 1 and 2 and high of 3 to 5. And even with that, you know, discrepancy in injury severity, treatment, or excuse me, next slide. Here we go. So these injuries behave differently. Improvement resolution are on the left of the screen, progression is on the right. High grade injuries in the red, low grade injuries in the black. So increased percentages of patients who have improvement or resolution of injury with low grade injuries versus lower rates of those events in high grade injuries, and then for progression, much more common in the high grade injuries. So more important for these patients to be getting some type of therapy, whether it be antithrombotic or antiplatelet. And then that begs the question of which one of those is actually better, or is there any difference in between administering one of those agents to these patients? And the short answer for that is, I think to date, there's no randomized data one way or the other that says you should be using antithrombotic or antiplatelet agent. I think it very much depends on the clinical context and then also where you have trained and practiced. But this was a meta-analysis that demonstrated with no treatment, 25% of these patients will progress to risk of stroke, versus maybe 10% with an antiplatelet agent and somewhere around 10 to 13% with an anticoagulant. Endovascular therapy is sort of included there at the bottom, and we'll get into that later. But these are just studies, and we can go through these very quickly, but there's essentially no good data on which type of blood thinning medication you should be using, an anticoagulant or an antiplatelet, and really it should be taken in the context of the overall injury burden. So if you have someone who has a head bleed and has just been cleared by neurosurgery to start receiving some type of anticoagulation, you know, do you want to use an antiplatelet agent that will have effects that in theory will linger? Or do you want to use an anticoagulant that may or may not have a reversal agent? All of those need to be taken into account when you're starting these patients on therapy. Endovascular therapy is actually quoted in our CPG as a potential treatment option for grades 3 and on. And I think this has sort of fallen out of favor as everyone with this injury grade should get this. It can certainly still be used in specific circumstances, but it is not nearly as popular as it was before. There are two studies, one in 2018 and the next in, I think, 2015, that compared basically pre and post implementation of more and less aggressive neurovascular intervention. This is the first study. This was out of Memphis, and this showed essentially no difference in stroke rates and no difference in BI-related mortality with a much less rigorous stenting practice for these grade 2 and grade 3 injuries at the bottom. So the only change was that they have, you know, collectively decided to use stents less and to rely more heavily on antithrombotic and antiplatelet therapy, and their patients do just fine with no real differences. This group similarly did the same thing, and you can see here that their cutoff was January 2005, so, you know, remote from here. 4 stents were placed after that versus 46 stents that were placed before that, and I think this was a 10-year experience, but there were no differences in groups or in stroke between groups in either of those time periods. So
your patient population is grade 2 and grade 3 BCVIs. In our CPG, we engage vascular starting grade 3 and above. So CPG basically says the antithrombotic therapy for grade 2. So I mean,
for even 3, that's a fair point. It doesn't include the grade 4 patients.
But
Yeah.
I'm just saying it does. You're saying that stents are not as good or as compared to thrombotic. A little bit of a mix.
Okay. Fair enough. And then the last study that we were going to talk about today is this transcranial Doppler and the utility for that for assessing for stroke risk and patients with BCVI. And really the group that does this proposes early institution of this screening modality. So essentially day 0, 1 after injury, and then doing this daily and assessing for any, first of all, the presence of any microembolli on the site of the injury, and then any changes to that. So if they start positive, if those studies start with a positive finding, do they become negative, and so forth. And so, and how does that associate with the outcome, the final outcome of stroke? And so for these patients, the group, these are all patients who had initially a positive TCD, so on their initial screening, and then whether or not those stayed positive, whether or not those studies became negative, actually did significantly impact their rate of or their risk of having a stroke after 24 hours. So a much greater proportion of patients whose TCDs remained positive ended up having strokes versus the group that became negative. A much smaller fraction of those patients ended up going on to have a stroke. They demonstrated that there was a stroke risk of about 2% with no microemboli, and then that stroke rate increased based on the degree of, or the frequency of microemboli per hour. So 0% with 1 to 6 per hour, 7% stroke with 7 to 40 per hour, and then 40% stroke risk with greater than 40 per hour. When they adjusted for Denver criteria injury grade, there was no longer a statistically significant difference between the number of emboli per hour, but there was continued very much positive association between whether or not that study was positive and then their risk of stroke. So this can be a very useful screening modality if available.
And then, did it matter which vessel?
It did.
It's only beneficial.
Yeah, so really only for cerebral artery disease.
Carotid.
Sorry, carotid artery disease, not for vertebral artery disease. Yeah. So the recommendations from EAST are at the bottom here. So using a screening protocol to detect BCVI, and then some of their ideas for what that screening protocol should encompass. In adult patients with BCVI, we recommend using antithrombotic therapy to prevent both stroke and mortality. And then for grade 2 and 3, we recommend against the use of routine endovascular stenting as an adjunct. And then our protocol here, so antithrombotic therapy for grades 1 through 3, with consideration, as Dr. Geis pointed out, of vascular surgical consult and then stenting for the higher grade injuries.
Did you do anything about follow-up imaging and determinant BCVI?
In here, I think there is a flow chart.
It's hard to what we do.
Oh, I'm not sure what our CPG says on that.
Indeterminate basically gets re-imaged within 48 hours. And then if it's, let's say, upon repeat imaging, 40% will resolve, 25% will be reclassified, usually grade 1 or 2, so it's dissection flat. And then the rest be indeterminate again. And it's questionable if the rest you would want to just give them platelets anyway. And then as far as follow-up imaging for grade 1 and 2s, you can follow-up image 7 to 10 days for those injuries. So again, dissection flaps. And then honestly, for grade 3 above, it gets a little vague. It's basically per vascular surgery, whatever called it. But there's a follow-up imaging plan.
So you'll see, I mean, Morton will use the TCD because he's from Washington.
Do we offer that here? Like, can we get that?
We don't have a TCD tech 24/7. It can usually be done during the week, but if it can be started, then it can be followed, and it only needs to happen for the first 48. But it's perfect for injective people that are like indeterminate or like not great looking grade 2 or grade 3. But to your point, it helps maybe select who should get stented. The other reason for some folks moving away from stenting being that, like Dr. Geis mentioned, very heterogeneous population, but also we don't really know the natural history of stents in the carotid artery of a bunch of 25, 35-year-old individuals. And then in the short term, right after you stent, you have to give them antiplatelet therapy, and you can't safely interrupt that. So I think it's you're between a rock and a hard place sometimes.
Bill, how about a asymptomatic GCS15 patient who's in a car wreck, has a seatbelt sign going across their neck?
I would get a CTA, a seatbelt sign across the neck. Yeah.
CPG would say that the seatbelt sign, but it needs to be associated with some sort of ultramosis, some sort of hematoma or significant change in the area, more than just like a plastic bruise.
Would you get a
Consultant actually has been shown not to be a good predictor.
Okay.
Predictor.
It doesn't fall into the kind of hanging mechanism that was mentioned. Okay. But it's good to know.
Usually that seatbelt sign has to be with something else, pain swelling.
That being said, clinical practice are different than clinical guidelines. You are going to get them on most people with seatbelt signs. So I would just, before you do not order it on someone with a seatbelt sign, check with your staff today.
Yeah.
Also, some of your staff of the day will want them on everyone that's getting contrast because it's not that much more radiation and not that much. And the risk of missing it, they would rather just screen stuff.
Yeah, I did a neck angio last night on a guy, MCC 27, came in altered, but he also got 200 heavy field ID.
Nice.
Yeah, so really couldn't get a good exam. He wasn't moving everything, but just had significant like facial trauma. Didn't look right, so we got it. He had bilateral PCBIs. Left side is like really narrowed, right side also narrowed some. And he's got grade 3 liver, grade 3 kidneys, subdural. He's got a lot of problems. But very timely talk for that.
Yeah.